1, 2.
1 2 1 2.
Welcome to our second episode of our new season, Financially Speaking. I'm your host, Drexwell, Seymour. It's such a pleasure to be here in your midst, bring you awareness and try my best to, educate you and educate myself as well about things that are financially. And of course, most things, almost everything have some sort of impact financially. And so today, our guest is the CEO for National Health. I know he was also a guest earlier on First Edition, but that's fine because, there are so much things that we could talk about. And with that said, I want to welcome Mr. Ralph on the show, and I want to congratulate him, first of all, in his position as CEO, which he's been serving now for the past 2 months. With that said, welcome to Financially Speaking.
I appreciate it, Drex.
Yes.
Thank you for having me.
You've been to my show before?
No, I haven't been to your show before. Financially, I had nothing to speak about, so I guess now I do. But no, it's a pleasure. I had the opportunity to be on First Edition, and that was a great time. And I know that we can expand a lot more here. So
Absolutely.
Thank you for agreeing to go the extra inning with me, if I should say it like that. For sure.
Oh no, national health is very important.
Yep.
It's an integral part of our country.
Mm-hmm.
It's not only that, we spend a significant amount of money on health,
Yep.
beyond national health, obviously.
Yep.
National health is just a conduit.
Yep.
Mm-hmm. Okay, so for those who are watching the show, explain to us because I know national health gets blamed for a lot of stuff.
Yep.
Explain to us the process in national health. How does it work? How do you get your money? And then how does it work when time to send patients abroad? First of all, tell us how does National get their financing? Because I know we have the plan, but that's not enough. So tell us about that.
Yeah, no, that's a great question. And as I said earlier this morning, our real remit comes from the ordinance, which allows us to collect on contributions. So most people in the country will work for an employer. And in the ordinance, we, as you know, would do 3% up to $7,800 cap,
Mm-hmm.
both from the employee and the employer. So our main revenue source and the real remit that we are to cover comes from those contributions. Now, of course, there are things in the ordinance that we aren't responsible for, but it has given us the authority to manage. One would be like treatment abroad.
Yeah.
So that funding actually comes directly from the government,
Yeah.
from the Ministry of Health. That's in
Yeah.
the Ministry of Health's budget. What we cover and what that 3% that we get and what we collect, or that 6% I should say that we collect monthly, that covers local care.
So the national.
Yes, yeah,
Mhm.
exactly.
So when you go to the hospital,
Exactly.
when you go to the private sector,
Yes.
you pay that
Yes.
over the
Yes.
threshold.
Exactly, with a very limited copay, right? Because we do, in all actuality, the copay is actually NHIB's as well, or it goes back to help cover services locally on island as well.
So for the private sector, you pay what, $35?
Yeah, for consultations, medical, and the pharmacies is up to a certain percent as well too.
Pharmacy is very generous.
Yes.
Based on my understanding,
Yes.
the prescription is very, very
Yes,
generous.
and so, and it's a wide range, of course, of things that we do cover. Now, not everything is on in our remit that we do cover, but we're looking to add more things there based on the need and what it could do for us as an insurer, hopefully in regards to, maybe limiting or cutting down and bettering, not having to send people abroad, maybe that will also help as well too. So, but really our main revenue source, and really I should say The only real revenue source that is truly NHIBs is really truly the contributions that come in. We do get a transfer to manage the treatment abroad, but that actually is coming from the ministry itself.
Mm-hmm. Do you know offhand, because I know you don't have your numbers in front of you, but do you know offhand what the annual revenue was for the last year? Do you know?
I don't know the exact number, but I do know it was north of 43 million.
North of 43 million.
3 million from the contributions. And then, of course, the treatment abroad, that's a whole nother element to itself. I mean, I think last year, I think that was north of, I think close to 70 plus.
The treatment abroad?
Yeah, the TAP program. So if you add the two together, you're looking at close to $115 plus million or so,
right,
give or take.
And the government also funds money for those in prison?
Yeah, indigents, those in prisons, those on social welfare.
And so that's different from the 40.
Well, that's included in that. So we would include that in revenues that we would say are NHIB's revenue. So that would be included.
Oh, okay, okay. So you don't get a special amount of money from government for that.
So so what we would do is we invoice them for, like we invoice them based on the numbers, based on the numbers or totals that would be under. So those would still be considered contributions, but the government is responsible for that part of that contribution.
I see.
Yes.
Okay. So those watching this, so imagine now you're getting $43 million, roughly $40 million, that we collect for the rate, the fee that we charge, the basic fee, which is 6%.
Yep.
And then the government spends between $60 to $7 million on treatment abroad.
Yep.
The money is transferred to NHIP, and then you pay the overseas
then we pay
suppliers.
the vendors, the providers.
Now, can you let us know, confirm that the payments are up to date? Because there are a lot of rumors that there are so many people who are denied services abroad because the payments are not up to date. The supply, some vendors are not taking us because they say we haven't paid.
Yeah, no,
You've heard that rumor?
I think that was a rumor. That rumor, we don't have it. That's not the current situation. If it had been before, it's definitely not there since I've been there. We are on good terms with our vendors. As you know, vendors do give you terms, so I don't want to say that we don't have payables, because we do.
Yeah, like 60 days, 70 days.
Yeah, but we are within our range of payables. We have, since the examination process has started, I guess that would have been a year and some change ago now, it has been stabilized. There was a time when, at that point, when the board was dissolved by the governor and the examination process came in, that there was some issues with payments to providers that did trigger that, but that has all been sorted. We are now on good terms with our vendors. There's no issues of us being able to non-acceptance or anything of that level, no. So we are on good terms there.
So we're in good standing with our suppliers.
Yeah, definitely.
Okay. And I mean, we still go to, I noticed we've been sending a lot of people to Cayman.
Yep.
Seems like we discontinue. It seems like there's a slowdown in sending people to the Bahamas.
Yep. Well, right now we don't have any of the Bahamas providers in our network currently.
Really?
Doctors used to be in the network, but we do every now and again. There could be a one-off, but it's not in our network currently. So our current network, we do have presence in the U.S. We do have presence in Dominican Republic, Cayman, Jamaica, Colombia are our main areas. Now, every now and again, there could be a one-off if it's a special circumstance that requires a person, whether it's a specialty situation or anything like that, that we would send someone outside of our normal network. But those are very special circumstances that would go to the board medical committee for approval and so forth.
But isn't the U.S. when sending someone to the U.S. isn't that special circumstances?
Well, we reserve the U.S. for more specialized, very specialized cases, right? Because there are some places within the Caribbean, but the U.S. is still for very special. Let's think of something like neurosurgery or something like that, where it would be a very precise procedure that needs to be done. That's when we would try to use the U.S. The most to make sure that we'd send them to someone in our provider network where we believe is a special provider that can handle such a case.
I see. But let's go back to the Bahamas, because I remember, if you could let us know what's happening, because I remember, I used to be the chairman, so I remember the Bahamas was utilized very heavily, and we have flights daily to the Bahamas. I remember when I asked about that from someone, they told me that the Bahamas is very expensive, and that's why we don't send as many patients to, as we used to in the past. But I just find it hard to believe because, we don't have direct flights to Cayman Islands. So sometimes we have to, most times we have to charter a flight to Cayman Islands, or you go through Florida, and sometimes you end up spending the night. So when you factor all that in, to me, that's also, could be a burdensome financially on the institution. So why is the Bahamas not in the network anymore?
Well, I don't know what had happened in the past as to why they currently aren't. I know that there are discussions to potentially see an opportunity with Doctors Hospital, I believe is one of the hospitals that we operated with, and I think that they've I think opened a new one actually, a new facility recently. So I know that there has been engagement to bring them back on, perhaps, and just to see where that might lead. So it's a possibility that it can happen. We are always looking for, like you said, closer access, all of those things.
And then a lot of us have family in the Bahamas, because sometimes we're sending people to Colombia. It's so far, and people have to leave their jobs, leave their family. No one, in Cayman, but at least in the Bahamas, if they have the services, a lot of us have family in the Bahamas as well.
No, for sure. I mean, we want to, of course, as I said earlier.
Of course, I know cost is everything, too, at the end of the day.
But back to that, costs and outcomes, I think we always focus on outcomes first. I believe
the quality of service?
Quality of service, specialty of service, too, what they can provide. And then, of course, cost is a big part of that as well, too. Like I said to Ms. Foreman earlier, if two hospitals had the same quality of care, then the deciding factors would be for the insurer at least, because our remit is a little different than just, than the medical professional, that our next thing would be cost, right? The overall cost, like you spoke to. And what we're finding is that, some of the providers that we've attached ourselves to as of late, especially Colombia, a lot of those hospitals are first in class in not only just the region, but in the world, actually. And they cover a lot of specialties, and of course it's a little harder getting there, and of course the language barrier, but what we want to do is really, for sure, get the proper outcomes, but what we're finding is it's like half the rate in some cases, and a lot of times.
I mean, I haven't heard any negative reports
for sure.
about Colombia, it's just that, the distance and
the language,
stuff like that. So speaking about the providers, explain to viewers how that process works when patients have to be sent abroad. Tell us the process.
So what we operate from, so let me take it from its infancy. I think this is important to say because there's there can be sometimes pushback when you, like Ms. Foreman raised this earlier, that sometimes a person may not want to go to, let's say, Colombia because of those barriers, or maybe skepticism. So what happens in the first instance for any provider that we bring on, it's a joint mission that takes a full delegation to go to vet that hospital. It's the Ministry of Health, it's the NHIB, it's the minister usually on that trip as well. And it's also representation from the hospital, whether it's the CEO usually and the chief medical officer. So it's a very vetted process. Of course, it's deep visitation, very hard, very detailed grading, negotiation in the back end, so that we ensure that based on what our volumes are showing on our metrics, that when we put a provider in the network, we vetted it for the people, right? To say that, if I wouldn't want to go here, if this isn't fit for me or for my family, that's sort of in the lens that you're looking at this at. So we can say to the public, and I just want to say to that, is that, that the providers that we do have in our network, we have full confidence in them. Not that they would be perfect, but that they are top quality due diligence. Yeah, top quality due diligence, that you can take that on. Now, to the other part of your question in regards to how does that process work? So that a referral first starts at the hospital. If you are flown out in any capacity, it would first start at the hospital with a referral.
Yeah, it cannot start from a private clinic.
It does start from the hospital, right? And it does get a referral there. Once that referral happens, depending on the urgency of it. But in either case, it always goes to what's called a JRC committee, and that committee is the committee in the hospital, the chief medical officer from the Ministry of Health, and our chief medical officer as well. So it's a very vetted process to say, okay, does this case really need to go overseas, right? Decision is made then there, and then that goes to our matrix. So it depends on what your acuity is and what you're diagnosed with, would let us know from our matrix who's the best in service and who's the best as far as costs and turnaround time that we believe, based on what we vetted and seen the outcomes. That's how we determine where you should go. So it's important to know that when we do make a selection for a patient, all of that backdrop has already been considered, and we're trying to send you to the best possible place for you to get the best possible outcome.
I see.
Yeah.
Well, let me tell you this. There are some private providers on island who, a lot of people, I'm in conversation with many different people.
Yep.
Some people do not know that, but I am. And some of these providers claim that they can do some of the services here locally for which we are sending patients abroad to do. Not everything, but some of the local providers say they have the capacity, they have the equipment, they have the resources, they have the practitioners to carry out those same services that we are sending some of our people abroad. Now, I know that's probably beyond your control. I do not know whether that's a decision that has to be done by the Ministry of Health, but I think we also need to look locally to see what can be done locally.
Yeah, no, that's a good observation, and I'm sure that I'm sure a lot of these conversations.
I already had conversations with the
with
ministry.
clinical providers in the ministry.
Yeah.
The plan is to, like we said earlier, is to repatriate what slowly but surely what we can, piece by piece. Just speaking with the minister yesterday, there's a strong appetite for that, and I think in the
You mean local? Using
yes,
locals?
local
All right.
providers. But I think that's going to be a greater focus, especially with the shift in how the TAP is going. There's a big greater shift for that. Now, I think from the ministry standpoint, there's going to have to be sort of a capacity sort of test on it, because once we say, hey, we're not going to send these services away anymore, truly do we have the capacity here for it, or how much of it can we really take on, and how much is the ministry willing to take on in that respect? So I will say in our strategic plan from the NHIB, working along with ministry, this is probably going to be a very high focus, especially coming into the new government year. So the backdrop planning has already started from our end.
So starting April?
Yes, starting April, I think we would have, hopefully, maybe one or two services that we could really consider maybe doing that with, whether it's with the hospital or the local providers. I know that, the ministry has already reached out to us to already start putting data together as to, okay, what would make sense to, whether it's like ophthalmology is a good example, right? I mean, it's small, but, we probably have enough here that we can probably bring something like that and maybe eliminate something like that, right?
Got it.
So just looking at stuff like that, we're going to be having a strong focus on. The planning is going to be starting now for preparation to have it ready to at least do something in the new financial year.
Right. Now, I know you worked at the hospital before.
I did.
And I know you say the process is, the hospital make the recommendations when a patient needs to go abroad, which makes sense. But how do we know that what the hospital is telling us is accurate? How do we know these patients? How do we know that this stuff cannot be done by the hospital? How do we know the hospital is not avoiding taking on risk or avoiding any lawsuits, so it's better for them to send people abroad? How do we vet that process to make sure that they're not, every patient, they just say send them abroad, send them abroad? How are we dealing with that?
No, I mean, that's a good question. I'll start with saying this, having worked at the hospital, for any patient, it's an inconvenience to have to go away. Even for the physician locally, it's sort of an inconvenience, and sort of a, physicians, and nurses and medical professionals, when they have a patient, they want to see usually the best outcome for that patient, and usually they want to be the ones to do that. So I know it's even a hard decision too when they have to say, hey, it's nothing more I could do here, and we have to send you off. But like I said, again, there are steps, there's second steps to the process as well, right, in most cases. Now, the only case that we wouldn't necessarily be able to vet it is a true critical emergency. I mean, like an air ambulance emergency. Somebody gets in an accident or something, we get them stabilized, but we have to get them out. And so no questions there. But the ones that you're probably referring to are what we would call urgent but not critical, right? So those do get vetted in the JRC meeting. So that's where
Okay,
that
what's
is
JRC? Joint?
yeah, the Joint Referral Committee.
Oh, okay.
So that does get vetted there, and we do have representation. Like I said, again, our Chief Medical Director, and then of course the Chief Medical Director of Ministry is on that as well. So there is representation, and I don't want to call it pushback, but it's to vet it, right? To make sure that, okay, have we tried this, and in that way. Now, with everything, I'm sure improvements can be done, and I'm sure everyone in that committee would probably say that there are some things that we can probably look at, and maybe, nothing's perfect, but for the insurer, it's important that, no case that didn't go because it's a cost, right? And so we do want to avoid that at all costs, yeah. But we are working closely, with the hospital as well to, like I said again, where there are cases where we can see, hey, had we had this in this situation, this would have been resolved, then we can make those recommendations with the hospital, I guess, and to say, hey, a change inquiry should be put in place to, maybe it's a machine or maybe it's a new service, right? But we do want to highlight those things and communicate, right? Because this is a partnership with the ministry, the hospital, NHIB. We all need to communicate. And I think that's something that we're going to, that I'm going to make sure that we try to get interrelated to make sure that we get better at, and we all want to get better at it. Yeah. Right? For sure.
So now, as an outsider or even insider, people who are inside, it's very obvious that we're spending a lot of money.
Yeah, definitely.
Very obvious. I mean, when we built these two hospitals in 2010, I believe that most of us thought that, more things are being done locally.
Yep.
So we have all these hospitals. And I see the government made a policy decision to discontinue sending persons on a work permit overseas on medical treatment abroad. Is that policy in place?
No,
now?
That policy is not officially law yet.
Oh, it's not. It's not.
It's not. It hasn't progressed there, but it's still trajecting to be that, right? I think that will, hopefully before the end of this government year, or this government financial year, that is still tracking that way. At least that's still where it's tracking.
So we are still sending people abroad who are work permit holders.
Yeah, so
we're still sending people abroad.
So at this moment, yes, it still hasn't, because it hasn't been law yet. We still do cover for that, for critical matters, for sure. And I mean, everything that we send away is critical, right? Yeah, but we do have there's still some things in there that has to be done before the legislation can become official. For example, defining what is major medical requirement for the employer, what the employer would need to, what's the minimum requirement, right? Because, for example, like air ambulance it would probably need to be something that needs to be in there, but it needs to be defined, and I think that's a part of the process to getting it to legislation.
I'm surprised that this hasn't been done yet, because I remember when the government made that decision, the government had mentioned, I think within I think the premier, correct me if I'm wrong, I think he said immediately, and I think the minister came back and said something about 30 days or something like that. So I'm very surprised to hear that that policy is not in. So we're looking then to see then the overseas medical treatment costs will basically be more or less the same or more.
Well, I think, at the end of this year, it's going to be sort of static and comparable to previous years. I think where we're hopeful is that change will affect 27, 28.
Wow.
Forward.
I'm very surprised. Because it's been...
Well, no, I mean, it's a process, right? I mean,
but I know they made the announcement.
Yeah, no, for sure.
The announcement's been going on, I think, almost a year now. If I'm not wrong, they made the announcement that persons are, whether I agree with the decision or not, but the government made an announcement that persons on work permit will not be no longer bearing the cost within, after 30 days or so, and stuff like that,
But I will say that the legislation is in its very advanced stages. It's very advanced stages. And again, there's some, other things like the consultation once it's fully in its full draft form that has to happen. Of course, employers have to know what to expect, like I said, with the major medical. So just some of those things that, critical things that, just to be in all fairness to everyone, I think is just what is going to take to get the legislation over the hump. But it's in its very advanced stages, and I do see it from everything that I can see where it's trajecting, that it should be ready for the new financial year. Yeah.
So when a new person comes to the island, currently
Yep.
they have to subscribe to the plan for 6 months before
Yep.
they
Yep.
could, is that correct?
Yep. So yeah, the legislation or the ordinance has it before you would qualify for TAP. It would be 6 months. Yep.
6 months.
6 months on the plan at minimum. Yep.
I see.
Yep.
And do you know, like, for example, is there a plan internally, like you say we have Jamaica, you say we have the DR,
Colombia and Cayman. Yep.
in our network.
Yep.
Say, for example, we have a work permit holder from Jamaica, right? Gets sick
Yep.
and needs to go abroad.
Yep.
Would you send that person to a place other than Jamaica? Or you treat them just like anybody else, depending on the situation? How does that work?
Yeah, so we tend to follow our matrix, right? Because again, a lot of the providers have different specialties, right? So let's just say, for example, and I'm not saying which provider has this specialty, but I'll just use it as an example. If provider X is specializing in cardiovascular, and you come across a serious cardiovascular case, we still would refer to our matrix to say who's the best in our matrix for cardiovascular services. Now, there's still, the matrix doesn't just only solely put it to one provider per se, right? Because it would give like a top 3. Now, let's just say Jamaica in that case might be a top choice, right? One of the top choices. We would consider that, and we do, and I think what is important to mention is that we do consider request if it makes sense for that case to do as such, right? For example, like that same one, like that patient might say, well, I'm from Jamaica, and it would be more convenient or whatever for me to go to Jamaica. And we would look at the risk matrix as well and say, okay, well, it's still in the matrix. It may be not the top one, and even though we would recommend and say, hey, this is there, but we still have them in the matrix, and we still feel that we still are confident that they would do that, but it would not have been necessarily number 1 on the matrix, but number 2 is still pretty good. So it's still there.
Okay, because I don't know how, I'm not familiar with all countries, obviously, but I would think that some countries, I don't know, may have a special rate for their citizens. I don't know.
Yeah. But see, when we send, we guarantee the service. So it's actually an agreement between us and the provider, right? So we have our negotiated rates too. So that's why it works that way. So it's not so much on that end. But again, like I said, there would be, in a case like that, if that was in the matrix for sure, we would consider it.
Yeah, I think that's something we should look into.
Yeah.
How long, okay, someone goes away, right? How long does National Health continues to pay the bill? Say, can someone be away for a year and you continue to pay that bill? Or is there a limit on how long someone could be away? Is there a limit on the dollar value of the treatment they're getting?
Yep.
Are there any parameters for that?
There is, and so the ordinance speaks to us as the insurance provider. We provide critical emergency immediate care and not long-term care. And so long-term care is defined as 90 days or greater. So when it gets to that threshold, like again, treatment abroad is still funded by the government, right? But when it gets to that threshold, the management decision of the treatment is then transferred to the government. So meaning that traditionally we would manage it up to a certain point, but any decision going forward there, we would then consult the government on, what would be the way forward that they feel about the case.
Once they exceed
that, because it's now getting into what we call long-term care, and then also high costs, right, for sure as well. But we do have reinsurance as well for, that kicks in up to a certain value that does protect against some of it, right?
Yeah.
But to answer your question, there is a limit technically on where we go with the management of it. It does go to 90 days.
90 days?
Yeah, 90
All
days. After that, the decision that is made is not in the management decision of NHIP only. It's in
The ministry?
Conjunction. It's really the ministry's
Yeah.
remit there that they would make the
So
decision.
you're just being
going
guided.
forward.
You're being guided by the
Guided
ministry
them.
then.
Yeah, so we would just pass the information on and say, okay, this is where the care is saying it's going, and they would make the decision in essence to say, well, should we continue on that, or the risk is now we've outdone it and it's now too risky now in essence.
Oh, okay. Because I know when my mom was in the hospital just opened.
Yep. Okay.
She's probably one of the first patients there, 2010, and I mean, I just asked her from an overseas point of view because locally, the hospital told us, basically that there's nothing else they can do for my mom,
Okay.
and the hospital's not a long-term facility
Yep.
that we need to
Yeah.
move to
Okay.
because there's nothing else they could do. And I was just wondering, how does that apply to patients abroad?
Yep.
Yeah.
And to be honest, usually it still would trigger as well too from the physicians and the provider as well. They'll usually provide a report as well too. But one of the things is as long as they are in that facility, right, until an actual decision is made, we have guaranteed the care. So whatever's accrued, we meaning, NHIB/TCIG,
Right.
which is funding it, we do fund it, right? It would fund until a decision
I
is
understand.
actually made, yeah,
I
for sure.
understand. All right. So let's look at the expenditure level. You mentioned at the beginning of the show, roughly we collected roughly around $40 million in revenue
Yep,
from the 6%
yep,
and whatever self-employed.
yep,
And then we get 60, 70 for
yep,
government for treatment abroad, because that's government's area. In terms of our expenditure, because always see people saying NHIB broke, NHIB broke.
yep,
Now I know NHIB is just a middle person.
yep,
The 40 million that you get, let's forget about the treatment abroad now.
yep.
Is that enough to cover your expenditure?
In the long term, it's roughly not enough to cover, because our expenditures, that would cover our bill that we would pay to the hospital. That's our real provider. And then it would also cover our normal operations, and then it will cover, what else would be in there? So yeah, that's the two
Salaries, payroll.
salaries. Yeah, that's what I mean under operations. So that's
Okay.
that's usually the big part of it. So I will say, from our last actuarial report, we're a bit short on that. So I think it's roughly maybe about, on a given year, about 200 to 300,000 short, and that will continue to happen because of the cost. Mainly, the hospital, the way it works is that cost increases incrementally each year. Now, one thing that has to be looked at, of course, is do we need to just even move the percentage of the contribution even slightly, right, to accommodate the growth that we've experienced, right? And so that's something that, the actuarial report the initial one has been submitted and it's being looked at.
So you had one recently, actuarial
So
report?
we had one that would have covered up to 2023, so that was just done, and now we're going to have one that's going to cover from 23 to 26
Okay.
to hit that triennial review.
And that's happening now?
Yeah, that's about to start September. It should be done roughly around November. But because of how recent the most recent report was done, although it covers that period, it was not.
It factored into current.
It sort of factored in some of the current stuff, but using that data. So we don't expect it to change dramatically in regards to what the recommendations were. But overall, we're slightly a little underfunded, just ever so slightly.
And then,
but it's almost on par with our with what we're
If we exclude all the
yes.
So if you're underfunded, the government you just request additional funding from the government?
Well, yeah, some of that just comes in a slight part of the subvention. Yeah, I would say in there that would cover the rest of that. Yeah.
Okay.
Yep.
And then and the money that you pay the hospital, is that the money? Because the government pays the hospital based on the budget. Do they send it to? I can't remember how it works. Do they send it to NHIB and NHIB pay them?
Yeah. So the way that it would work is that the hospital would invoice TCIG or
Based on
Ministry of
their
Health,
budget,
based on their
and
their budget.
they get billed monthly.
Yes, they get billed monthly, and then that bill is then transferred to us because it really the bill for the clinic, because it's probably multi parts of the bill, so I think that's why they bill it that way.
Okay.
But then they separate the
So the
part
clinical
clinical
portion-
portion, yes,
Is what the funds that we collect from our clients that we
Yes.
use,
for the
To pay.
Yes, exactly.
and then the government has all those different facilities.
Whatever
and
facilities else, yes.
I see, because I know that Yeah, that budget I know is pretty high. Yeah. Uh-huh.
Yeah, no, for sure. It's well, I mean, and again, I guess in the bare bones of it, and not to get too
But it's still not as bad as overseas medical
no,
treatment.
no, for sure. No, I mean, it would never be as expensive, right? Because to do something locally will always just be
Yeah.
naturally
Yeah.
cheaper to do it. But again, healthcare costs, and as you would know, as being in the
It's
financial,
exhaustive.
it's very exhaustive. I would tell people, hey, if you want to see a real healthcare bill, have a situation even if you have private insurance, and see what a hospital even in the U.S. would bill you for it, and what it would cost for you to even. Most times you have to pay a deductible, and it has to be up to like 25,000 before they even kick in,
Yeah.
right? So healthcare and insurance and all of this it's a very costly industry, right? And it's only going to keep increasing cost-wise. I don't see it coming down anytime soon, for sure.
And that's why I know this is not under your portfolio, but I personally believe that the government needs to invest more locally.
Yep.
I personally believe whatever. I mean, I know IHC has terminated their contract, but I believe that the government should have invested more at that hospital, so we don't have to be sending persons abroad. And I think that was a downfall on our part as well. I think there was an opportunity for us to invest more. We didn't do it. I don't know why. I'm assuming it's because of our relationship, because the money that we're spending, sending persons abroad, we could have built 2 more hospitals. I'm just saying. I mean, I know now they told me this polyclinic and all that stuff, but I believe the hospital has capacity. They have space. There's space that's not being utilized. The hospital in Grand Turk is underutilized. I believe that we should invest more locally, and by investing more locally, we could even bring specialists here from time to time. And even if we could even have full-time specialists here, and we could promote. We keep talking about this health tourism. We could promote that as well. I went to Cayman Islands, and I think I told this before. I told it on my show before. Mm-hmm. I had to do a procedure, and Cayman told National Health to send me. I arrived. Mm-hmm. So I arrived I went through Miami. No, I went through a charter. They had somebody else on the charter.
Okay.
So I went on Caicos Express. I came back through on Miami. And they told NHIB to send me. I arrived. Okay, that's Saturday.
Yep.
They said the procedure will be Monday. Mm-hmm. Monday came. They came and told me that the doctor supposed to do the procedure is still in India. He didn't get his visa.
Okay.
Okay? And so my bill was $7,000.
Okay.
$7,000. So there are some holes and some gaps. I know sometimes it's beyond our control. But they should have been held accountable for that.
Yep. And to be honest, I guess this was before I was there. We do adjudicate the bills, though, right? We would adjudicate those. So just because that bill said that didn't mean that that's what we paid, right? Because it usually does go through.
I don't know how he got the bill.
Yeah.
The bill,
Well, it came to you directly.
The invoice came to me.
Well,
and I was shocked when they see $7,000.
Because you're financially speaking, that's why.
I did one dialysis treatment.
Yeah.
Because, and then that was it. And of course, I spent, 3 nights, and,
Yep.
I came home, I think, that Tuesday.
Yep.
After they said that, the doctor cannot accommodate me.
Yep.
And $7,000
Yep.
the invoice came to.
No, for sure. No, and I, like I said again, we do adjudicate the bills, and we do review those with our claims department. But I do want to just touch on one thing which you started with, and you spoke about maybe the loss opportunity, and that we might have lost over the years, right? And I do agree. If we all honestly look at it, we would probably all say that there was probably time lost and opportunity lost. But like Warren Buffett would always say, the best time to invest was probably yesterday. The second best time to invest is today. So we're now got to work. We have to learn. We're learning from the past. We've all learned from the past. I mean, and I think it's an unfortunate thing, and I think the Premier mentioned it as well too. I think what might have really, how you start is sort of how things are going to finish. I think, having the interim government at that time, when the hospital and NHIB were both in its infancy, I don't know if that did the country well in during that phase. So I don't know if we ever met those metrics that we would have met had we had, functional elected government and ministries and all of that stuff working as it should work. And so, but like I said again, there's never a lost opportunity. You know, I mean, an opportunity passes, another one comes. So now we have to take full advantage of it. And I think everybody is ready to move forward with that. I know that we at NHIB in our culture and the things that we want to do, you know, we're going to play a big part in that. And so we're going to take advantage of it now for sure.
I mean, can you share with us, are there any plans with the organization to review? I always feel and still feel, I always felt and still feel that the NHIP is a very generous program.
Yep. Okay.
That's my feeling. I may get beat up for it, but it's okay.
Yep.
Do you know if there are, people come to this country, right? And they're just amazed at the treatment that we get from National Health.
Yep.
We had a very good doctor who just left. He said, Drexwell, I've been all around the world. I've never seen anything like this.
Yep.
You actually pay a national, you only pay $10 when you go to the hospital.
Yep.
To treat, I mean, it's so generous.
Yep.
And are there plans to review the benefits that we are giving our subscribers? Are there plans to review that? Now, I know the rate might need to review, that's different, but are we reviewing the benefits?
Yep. No, and and I mentioned this to Cheryl as one of the things that, over the long term, and even in the interim, but more so in the long term, is to really define the benefit more detail, have a more detailed defined benefit. One of the biggest things that, as far as cost is considered, is just simply that what you said, right? Is that we do need to probably, and to be honest, I mean, it's been 14 years, right? It needs a review. It needs to look at what environment we are living in now. I think when we started the plan, when the plan started maybe 14 years ago, I think there were maybe like 26,000 subscribers.
14 years?
I think 2012, yeah. That's 14? Am I doing my math right? Something like that.
It didn't start before the hospital?
Or maybe 2010, but
the hospital opened in 2010.
2010, right? I think the NHIB.
I think the plan started before that,
But it might have been.
And then it probably came into effect when the hospital was opened.
When it came in effect, and but let's say between 14 to 16 years, we've doubled, 2.5 times as much the registered members.
The
right?
country
it's just
growing,
that much bigger, right? And then we probably have twice as much tourists, right, on a given day anyway as
twice
well
as
too.
much population.
Exactly. So the benefit has to be defined now for this 60,000 plus, perhaps I don't know what the official census will say, but I would assume we're at least at 55 to 60,000 in population, right? I know from our subscriber base we're well into 50,000. So it might be 70,000 as the population.
We're around 50,000 subscribers?
We're just
that
close.
includes children?
That includes, the whole base. So it's close to about 50,000, right? So, and we know that we probably, and there's a call, we need everybody to register, right? But we know that we're a much larger country now than we are just population-wise. And so, to your point, we have to, one of the key things in making this a more sustainable plan is that we have to then, as a country, we have to be willing to accept more defined benefits and define limits, right?
Yeah.
This plan is not designed to, say, for Ralph or for Drexwell, to say, hey, it's gonna be able to do everything for you, right? And maybe a part of that might be a mix of some part of like having a bit of private insurance over the long term. We don't know, but we know that we have to probably define that plan, define it a lot better, and then execute from there.
Yeah, because I know many people that are taking advantage of, the plan, especially the pharmaceutical.
Yep.
And where it's just amazing how expensive some of these prescriptions are.
Yep.
And this particular thing that one was telling me that it would cost them about $7,000 in Canada.
Yep.
to on a monthly basis to get this pharmaceutical prescription.
Yep.
And so they just tag along, and I don't know how they on somebody's dependent or something, and so they don't have to pay that $7,000 because they're getting it here through the NHIP system.
Okay.
Because I think, if I can remember, I think anything over $25, I think NHIP covers.
Yep. So that's what.
And so it's generous.
Yep. And again, some of those we'll have to review. We're gonna, it's a piece by piece piece by piece product, but we're going to have to review the benefits. We're going to have to review what those rates are. Thank you for bringing that situation up.
Yeah,
I'm sure that there's a lot of
but
things
but
that
yeah.
that exist like that. But we as we course correct, I think all of those things. It will never be perfect, but we'll have a tighter
but
grip on
we need,
all of those
we need
things.
more efficiency, more
No, for
improvement.
sure, for sure,
Yeah,
for sure.
yeah. So as this new CEO for NHIP, what do you see? What do you see yourself? What do you see the organization going between here now and in the next, I don't know, 3 or 4 years?
Yeah, so I would say, critical things for us is, work partnership is going to be at the forefront of it, right?
Okay.
Definitely communication with Ministry of Health, hospital, NHIB, local providers, and even our international providers more on a basis like that. But really locally, the partnerships locally will have to be increased, and we have to really boost that up even more, right? Because we are all in this together. When I look at it, I look at one healthcare cost, right? And as I told Cheryl, we're spending, 32% of our budget just about is roughly on healthcare alone, the Ministry of Health. And that's various things, but most of it is health itself, right? I would say at least about 28% of that is health itself. So partnerships to get services back or to bring services here that will make a significant difference. Like you said, trying to see where we can get it with the hospital that needs, expand into where it needs to get to. We'll see what happens with going forward there. But then again, the cultural change as well. Like I said again, even defining that benefit more and having that cultural shift and how we look at the NHIB as well.
Yeah.
So really, it's just really pushing for that sustainability of the product. It's going to hurt a little bit in some ways, but I think in the overall, the grand scheme of things, I think it's going to be a little pain for a lot of joy because, I think peace of mind is what we always want to have people in our country having to know that this here, if something happens to you, the last thing you want to be worried about is how would I afford to have my child being taken care of myself in a hospital or my parents. So that's really where we're really trying to gear toward.
I always feel too that that I know I had the Ministry of Health on the show before, the last season, and they say they are doing more, promotion awareness. I think that there is a lack of health awareness in the country.
Okay.
And I think that a lot of times when we go to the hospital, it's almost too late.
Yep.
And so I think we need to bring more. I think the ministry, along with NHIP, should partner to do even if it's monthly, some sort of regular programs, because prevention is the key.
Yep. No, I agree.
We don't want to be in a situation where people are already sick. We want people not to be.
Yep.
We want people to be healthy.
Yep.
And one way to do it is to bring awareness. Here's what you should do, what you shouldn't do. I believe in testimonies. I believe that we could have stories of people who did it, and I think that's what we're lacking.
Yep.
We need to bring awareness in the country.
Yep.
We need to encourage people how to eat healthy. We need to encourage people to go to the doctor on a regular basis, especially men.
Yep.
Because we don't like to go to the doctor.
No, we don't.
We need to encourage that because they tell you when you're sick,
Yep.
it just changed the whole, and especially depending on the illness you have, it just changed the whole lens. It just changes you.
Yep.
It just, it even changed your mindset.
No, I agree. I agree.
And I think all of this can be avoided if we educate people more and they listen, they abide by it. And then another issue I know I always talk about it, we are approving work permits with people who already have high disease. And I know that's beyond their control. That's something I talk about even when I was chairman. They say, oh, that's discrimination. But all those different things, I believe if we deal with it, it could reduce our health costs.
No, I mean, I agree. I mean, with awareness is definitely, and we spoke with that with just even our PR from NHIB, but collaboration with Ministry of Health, definitely want to take that on. And I know the ministry is eager
they have a department,
to definitely want to get a lot of this in. And of course, primary care is a big focus for them, and that's going to do a lot, hopefully, with preventing things from ballooning before it has to go to the secondary level and, God forbid, the tertiary level. So definitely want to have those things in place too. But I do want to also just encourage, all of us to, be mindful of ourselves, because there's so much education out there already. And, your health is a personal matter, right? Your health and your peace of mind is personal. So definitely want to implore all of us as citizens, maybe.
And residents.
And residents, citizens, residents, visitors, everyone, just to say, hey, maybe have one less beer a week, it might make the difference, or, some of we love our island food is good food, but it's not always good for us,
and eating
so
cheap doesn't mean,
it doesn't mean that, so.
I know we're living from paycheck to paycheck, and
so,
sometimes we can't afford to eat healthy.
But
I realize
you bring up a good point too, and I mean, that's gonna be, so health, all of these things are interconnected, because cost of living forces, necessity. And necessity usually forces unhealthy eating and unhealthy habits, right? Or even having to work 2 jobs and, and all of that. So it's everybody's business here, and which is why we need to bring healthcare costs down, so that we would have more funds available for education. So we'd have more funds available for infrastructure and those things that we need to really help the citizenry a little bit more, for sure.
We must need to do, like how America has financial literacy.
Yep.
We must need to do health literacy
we need
in
that
the
too,
schools
for
as
sure.
well,
For
because
sure, we do.
it's critical. I mean,
for sure.
The health is, a lot of people are sick.
No, you are right. But the number one thing, and I'm not a medical physician, but I guess the number one thing is what you're putting into your body is doing the most, either doing the most good for you or the most bad for you, right? And so even our schools and how we talk to our lunch providers and what sort of things we need to make sure is included on the menu, right? I know when we went to school, we had chicken at 9 o'clock, fried chicken, but it was good,
Yeah, I remember.
It's good. It tastes good, but it's probably not the best decision, Maybe that could be a 12 o'clock meal, and that 10 o'clock meal, at least we can encompass some fruits and things of that nature, right?
Yeah. I remember one of my former coworkers at Cape Moelis said when she went to the doctor said, "Why are you eating pork? You want to look pig? Why you want to look like a pig? Why eating cow?" And say all of that. Just turn the ray off. Before we wrap up, can you tell the viewers what's happening with the exam? Are those? Is that, I don't know the name of the company? Are they still on island? Is that examination still going on?
Yeah. So the examination portion of it is done. That was the first year. We still do have them on, not so much in the examination part of it, but more in the helping of implementing some of those things from that examination in place. So we do still have them. They're not on island as they were regularly. A lot of it now is being done from remotely. And
how long will they be available for? Providing the services here? Is that soon end? Will that end soon?
Yeah. So that service, at least as it stands now, we expect that to still go until December, that process. And it's really some key parts of that's still a part of that. And one of the key parts is from our IT and major projects complement is with the NISS project. So they're heavily involved with helping us with bringing that part of it on. Once those key parts are done, but again, it's more so managed by the ministry, but they're still on,
I ask you that because I know you can't say much about it. I ask you because we always have, so to speak, consultants come here, and sometimes I don't see the need for some of them. They are understanding our system by talking to us when we could do those things ourselves. We bring these consultants here, and they're not going to stop. As long as they're paying, they will find ways to continue consulting. And I'm not sure how we're benefiting. That's why I ask you that.
No, that's a fair ask. I know that you wrote about it. No, I think
they're telling me I have to wrap up, even though we didn't start on time.
But. No, but I'll just say to that point, I just think based on the dire need of where the organization was, it probably was the ask for that in that time.
Since I'm being pressured to wrap up, do you have any closing remarks as we wrap up?
No, like I said, I just want to first thank you for bringing me on Financially Speaking, and I just want to thank you for allowing me to come on. I was on this morning, but I just want to say to the public, just thank you again for tuning in to me once again. That's twice in the last 2 hours. It's been a pleasure. I hope that this interview would have given you a little bit more of the details into sort of how the plan and works and sort of where the funding and where we are at. And like I said, again, my doors are always open. Just send a shout or email to us at NHIB, and I can answer any further questions. So just thank you, everybody, and thank you, Turks and Caicos. I promise no more of me today. That's it.
Well, I want to thank you all for watching Financially Speaking. I want to thank Ralph for being our guest. And I want to encourage you, as we mentioned earlier, to please, know the status of your health. Yes, you're paying national health. Yes, something happens to you. You should be taken care of. But we want, taking from me, who has health issues, we want a point in our lives where you don't have to be going to the hospitals, right? And one way to do so is to prevent it from happening by being healthy, living healthy, eating healthy, and going to the doctor on a regular basis. If we could do that. We're spending a lot of money, and of course, no government doesn't think it's good enough anyway. They will spend money no matter how much it costs because, you are a citizen and a resident. They want to make sure you take the health. But at the same time, it's more about money. It's about living better. When you have health issues, sometimes there's certain things you cannot do as you want to do. Like me. I used to love to travel, but I don't travel much anymore. I love to travel, but because of the condition that I'm in right now, I can still travel, but it's be very costly for me to find those partners to do my services. And so I don't want you to be in that state, and you don't have to be in that state. And even if you're already sick, it's never too late to get better. And so I just hope, though, one more thing, that the government, I know they're watching, that they invest more locally in our hospitals, so we wouldn't have to be sending people abroad. No matter what relationship they have with Intel Canada, let's invest more locally so our people can be treated here locally. And we can invite people from other countries to come here and use our facilities, and they can make extra money from that as well. Thank you for watching Financially Speaking.